Good morning or afternoon, everyone, and welcome to this next workshop of the Unity Conference. My name is Aurora Grant-Wingate, and I am NACHW's Member and Partner Engagement Coordinator, and I get the pleasure of introducing our brilliant presenters for today's workshop. For this workshop, we will have two 30-minute presentations with questions at the end. Our first presentation is called A Framework for Effective CHW Organizations, which will be presented by Denise Hernandez and Julie St. John. Dr. Hernandez received her PhD from the College of Architecture, Planning, and Public Affairs in Public and Urban Administration at the University of Texas at Arlington. She earned her Master's of Public Health from the Texas A&M School of Public Health and a Bachelor's of Science in Allied Health from Texas A&M University. Her research focuses on the incorporation of community health workers to bridge the gap between the patient and healthcare system, as well as CHW workforce development. Denise is the founder of the DFW Community Health Worker Association, for which she now serves as the executive director, as well as a member of the founding board of directors for the Texas Association of CHWs and Promotoras. Julie St. John is an associate professor and associate dean of the Graduate School of Biomedical Sciences. TTU-HSC Abilene campus. She has her doctorate in public health from the University of Texas Health Science Center at Houston School of Public Health. She is a Texas certified CHW instructor, serves on the Texas CHW Advisory Committee from 2011 to 2020, and serves on the board of directors for the Texas Association of Promotoras and Community Health Workers, a member of the APHA CHW section, and has worked with CHWs for 20 years. She founded the National CHW Training Center at Texas A&M School of Public Health, and she was the co-investigator on the CHW Core Consensus Project Phase 2, 2016 to 2018. And with that, I will hand it over to our two presenters.
Thank you so much, Aurora. So my name is Denise Hernandez, and today we're going to be presenting on a framework for effective CHW organizations. And I just want to say this was a part of a larger piece of research for my doctoral dissertation, and so I'm happy to be able to share that with you today.
I am pleased to be a small part of this as well, and Denise did a fabulous job. So hi, everyone. Good afternoon. Julie St. John. It really is an honor to be here. So at the end of this presentation, we really hope you'll be able to describe the organizational performance, what that is, what it means. We hope you'll be able to explain and understand this relationship between membership satisfaction and organizational performance. And then lastly, to be able to demonstrate how you could adapt this framework that we're going to talk about and present to your own community health worker organizations. So just a bit of a background and introduction to community health workers in Texas. So at the end of 2020, December 31st of 2020, there were 3,776 certified community health workers in Texas. So as many of you all know, Texas has certification of community health workers and instructors. And this is a decrease from 4.5% compared to over 3,900 certified community health workers at the end of 2019. And this percentage of community health workers that are renewing their certifications increased from 33% in 2019 to 46% in 2020. So in Texas, community health workers must complete at least 20 hours of continuing education every 2 years to renew their certification. So 10 of those hours have to be approved DSHS certified continuing education, and then 10 can be non-certified hours and include a variety of other conferences and self-study. So CHWs can renew a certificate that has been expired if it's less than 1 year, and they simply need to submit a renewal application that documents they completed the required continuing education. So the percentage of community health workers renewing their DSH certification, we talked about that in this figure, it increased from 33% in 2019 to 46%. And there is a pattern in this number of expired certifications in 2020 when comparing CHWs based on their language preference, and then expired CHW certification initially was based on training, where Spanish was the preferred language and it accounted for a higher percentage, 77%, of expired certifications than those with English as a preferred language at 41%. So expired CHW certifications initially certified based on experience were higher for those with English as the preferred language, or 59% than those with Spanish as the preferred language. So I'm going to talk a little bit about community health worker organizations in Texas, as it sets the stage for which this framework was developed. CHWs really need the social and professional support to be effective in their roles. And by nature, CHWs are very collaborative. They're community-based. They help each other and they support each other, and so that's really needed. Community health worker organizations, as such, they're community-based professional organizations that are formed to support these unique needs of community health workers. And there really was this lack of research that showed us this effectiveness of organizations in providing support. So we know that they exist, but we're not sure if they're effective, and if they're effective or not effective, why? So that's really what we were looking at here. So what was unknown? Well, the available CHW literature, again, primarily focuses on the effectiveness of CHWs, right, and how they improve health outcomes in vulnerable communities. But really, there's this gap in the literature that recognizes the importance of addressing the professional and social needs of community health workers. And so we were looking at this effectiveness of organizations to provide the support, whether or not the support provided by organizations plays a role in how long a CHW continues to work as a CHW, so their longevity, and then also whether engaging in a community health worker organization increases the likelihood of certification renewal. So these are some of the questions that were driving this research, because there was a gap. And lastly, that brings us to why. So why is this important? Well, there really is a need to understand how organizations and community health worker advocates, I consider myself an advocate, how can we support community health workers to continue the work that they do? Because we all know, and the literature does show, their importance, right? How they help communities. And we also, then by understanding the needs of the community health worker, the organization can better align their goals and activities to support community health workers, which is why they exist. So again, there's this need to understand how organizations and CHW advocates can support CHWs to do the work. And then in states like Texas that had a certification process in place, there has been this steady decline in the renewal rates until 2020. And so we want to understand why, and if CHW organizations can make a difference in that. So I'll turn that over, and thank you so much.
Thank you, Julie. And so as Julie briefly mentioned, there's a significant amount of research in the literature regarding the effectiveness of CHWs. We know that they are effective in increasing or improving health outcomes, increasing education, preventative health behaviors. But again, there's a gap in the research regarding strategies to provide professional and social support to CHWs so that they can continue doing their work, so that they can continue to be skilled and committed to the work that they're doing. And so because there was such a limited amount of research, what this research study did was looked at literature from the public administration field as well as the organization literature. And so what I looked at in those two different fields of literature was trying to understand the importance of member satisfaction, trying to understand the purpose and the function of professional associations. So what is a professional association meant to do? How do they measure whether they're being effective? And really, how can we take that and apply it to community health worker organizations that are so unique from other professional associations like a medical association, nurses association? We know that the needs of CHWs are very different. And so in looking at the primary function of CHWs overall, or primary function organizations, overall professional associations are established to support the needs of its individual members, the profession, and the larger society. Supporting the individual needs is considered to be the most noticeable function of a professional association. That includes needs for education, for information resources, advocating for individual needs, such as pay, which we know is a big deal with CHWs. As far as characteristics of effective organizations, much like other organizations, it depends who you're asking, right? It depends on your stakeholders. If you're accountable to a stakeholder who is a funder, then of course the revenue is going to be more important, whereas if you ask a member, then their member benefits are going to be most important. And so it's really based on perception and the stakeholders that you ask. As far as measures of effectiveness, the most frequently used measures of organizational effectiveness were meeting the organization goals, and board effectiveness, responsiveness to their stakeholders, resources, and the organization's reputation. Member satisfaction was also a key factor in organizational effectiveness. So organizational theorists proposed that there's a relationship between satisfaction, member satisfaction, and organizational performance. And so that's what I'm going to explore a little further. Research does argue that if the member is satisfied and happy with the organization, they'll work together to make sure that the organization accomplishes its goals and the organization is effective based on what they deem to be effective. All right, so again, let's talk a little bit more about member satisfaction. So there's an existing relationship between member satisfaction and organizational performance. So we highlight the importance of supporting the individual interest of its members as a key and universal function of professional associations. So the research states that if the individual is satisfied and happy with an organization, again, they're going to work together. They're going to have a positive attitude towards the organization. They're going to want to engage in activities and events, and they're going to want to refer their peers. They're going to want to renew their membership to the organization. And so if the member needs are met based on the member benefits, then that individual is going to be satisfied and will have a positive attitude. This all seems pretty, of course, it makes sense, right? But what does member satisfaction mean? What does that look like? What are those member benefits, and how do you measure that? And what we believe to be true and common sense really true and common? And so before I go into the actual framework, I want to go over some definitions because you're going to see these in the framework. And so just so you can understand what I'm referring to. So member satisfaction is measured by needs fulfillment and perceived organizational support. So needs fulfillment, this refers to whether the individual feels like their individual and professional needs are being met by the organization. Perceived organizational support describes whether an individual feels like the organization provides professional and personal support. That can look like continuing education, if they feel like the organization cares about them, their personal needs and professional needs. And so you can see how they go hand in hand. So when members feel valued, they're more likely to engage. The organization plays a role also in developing the individual's social identity. People gravitate towards social groups with whom they share similar values, goals, and they engage in organizations where they can identify with the organization's purpose and goals. And so members who develop their social identity, whether it's professional identity, individual identity, through an association, they're more likely to be satisfied and want to renew their membership and continue to engage. So moving back to behavioral intention, so this is based on the theory of reasoned action for those of you who may be familiar. What this theory argues is that the most important predictor of behavior is intention. And so if here, behavior intention refers to an individual's intention to join, engage, or refer the organization to a peer. So in this case, if the CHW believes that becoming a member and engaging in the organization will result in having their professional needs met and gaining a supportive environment. They'll have a positive attitude towards the organization and intend to renew their membership or intend to engage or intend to refer the organization. So to guide this research, a framework that uses each of these components was developed, and it focuses on member satisfaction as a key measure of that perceived organizational effectiveness. Also, we will take into consideration the importance of organizational capacity to the overall perceived organizational effectiveness. While researchers agree that meeting member needs is important, a comprehensive assessment of an organization also includes those structural components of the organization, such as the board composition, the organizational structure, the stakeholders. So it has to also, to some capacity, include an organizational capacity assessment. So to conduct this study, data collection tools were adapted and developed to gather information. Again, we don't have existing research regarding this topic, and so the tools had to be developed. The data collection consisted of a survey and individual interviews. So in Texas, where we do have a state certification, we have the advisory committee or advisory board. They, in support of this research, they disseminated the survey to all the CHWs and instructors in the state to complete this online survey. Of course, shared it with our existing organizations, word of mouth, and so try to get as many responses as possible. The surveys, again, were administered in English and Spanish, so they were bilingual. We had a lot of CHWs that spoke Spanish. The survey was meant to understand CHW participation in organizations. What are their motivations? Are they satisfied with the member benefits? And to touch on each of those constructs that I shared. We also had an organizational capacity assessment that was shared with the organizations. And again, we did individual interviews to learn a little bit more about each of those constructs. So this is the framework that was developed. And so using these variables, a path diagram, which is what this is known as, was developed using a statistical software tool. It's called AMOS. That may not mean anything to anybody, but this was a statistical tool used to assess the relationship in this path. And the reason it's called a path diagram is because not only am I seeing are these things correlated, but does trust lead to perceived organizational performance? Does that lead to member satisfaction? Does that lead to member behavior attention? So it assesses the path of the framework. And so I had to play around with the framework, and I had a general idea going in on what the framework might look like, but I wasn't correct. And so I had to move some things around to get a framework that really, that was statistically significant and really showed and identified what leads to increased member satisfaction and intention to engage in an organization. And so I'm going to talk through a little bit of these relationships. So first, perceived organizational support directly influences behavioral intention, and you'll see that line going straight through behavioral intention, as well as identification as a CHW or organization member, so that's social identity, and with perceived organizational performance. And I'll talk about that a little bit more on the next slide. So the most important determinant of an individual's behavior was how they perceived the quality of professional and personal support by the organization. So that perceived organizational support, that was the most important determinant of behavioral intention. So this really coincides with the argument in the literature that as professional organizational support strengthens, the desire to commit to the organization also grows. And again, the literature also highlights the role an organization plays in developing that social identity. So we saw this in the literature, and now we're seeing that it also applies to community health worker organizations, that organizations can help develop an individual's social and professional identity. And then as far as the perceived organizational performance, the trusted organization, needs fulfillment, and the organizational support all influence the organizational performance. And so this really helps us see that, again, perception, we're CHWs, we know that our perception is our reality. And so this goes to show that as long as the individual feels like they can trust in the organization to advocate for them, to advocate for the profession, and that the organization is doing what it can to meet their needs and provide that personal and professional support, they're going to have a positive perception of the organization. Perceived organizational performance, you'll see then influences member satisfaction. And so the results expose this relationship from organizational performance to member satisfaction. Members who perceive the organization to be effective based on, again, the needs fulfillment, the trust, and the support, they'll also, they're more likely to be fulfilled with the organization and be satisfied with the organization. This really supports what the research says about the importance of understanding the effect of organizational performance on an individual's approval or behavior towards an organization. And so again, I keep alluding back to the literature because we don't have much literature on this topic in the CHW field, but we're borrowing from other literature, other fields to apply them to our field. So member satisfaction influences behavioral intention. According to the literature, member satisfaction is related to retention and referral rates. And social identification as an organization member or as a CHW influences behavioral intention. And so this is just a brief summary of all those relationships. I wanted to highlight them on the diagram though, so you can see each of them. And so I just threw this up there. I'm not going to talk through all of it, but I just wanted to point out that even though this path diagram, again, assesses and determines the strength of the relationship from one leading to another in this following this path, aside from that, all these variables are positively associated with each other. And also most of them were statistically significant, but more importantly, one of the ones that stands out is that the likelihood to renew certification, again, this is in Texas, was positively and significantly correlated to behavioral intention, so an individual's intention to engage in an organization, as well as identity as a CHW organization member or as identity as a CHW. I mentioned the organizational capacity. You'll notice that that was not in the framework. So while it was not included in the proposed framework, because that again focused on membership satisfaction, we did conduct an organizational capacity assessment based on this, it's the SOGC. So this specific organizational capacity improvement assessment was developed for health professional organizations that were either conducting their first organizational assessment or that they wanted to focus on specific areas. And so because a lot of our CHW organizations are fairly new, this is very, very appropriate. And so with permission from the owners of this assessment, I adapted the assessment to our CHW organizations and gathered data from that. Again, that doesn't necessarily play into the framework, but it is also important to assess that internal organizational structure so that when you identify those member needs, you can also hand in hand identify how does your organization structure support, or maybe where do we need to change our structure to support those needs. And so this capacity assessment focuses on the 5 core dimensions for sustainable professional organizations. So it asks questions about culture, operational capacity, performance, external relations, and function. And so again, this is open and available. I did adapt it to the CHW organizations. Happy to share that. My contact information is at the end. Also, it's encouraged to bring an external individual in to conduct this capacity assessment. So applying the framework, I not only have a few minutes left, so I'm almost done applying the framework. So if you're an existing organization, adapting the member assessment and the organizational capacity assessment to your specific organization can really help you identify areas for professional growth. Again, the member assessment is based on these constructs of the framework. So I know the framework works, so that helps me know that the member assessment accurately measures what I'm trying to measure. If it's a new organization, these tools can be used as a needs assessment to gather information about what resources already exist and what resources or structures are needed to form a high-performing community health worker organization. So again, just in summary, the most important determinant of individuals' behavior was how they perceived the quality of professional and personal support. Behavior intention was a key indicator, and there is a positive relationship between social identity and certification renewal, and a positive relationship between behavioral intention and certification renewal. There are efforts to expand this research outside of Texas to see if the framework continues to hold true. But again, this is based on the literature, and so I do expect it to hold true outside of Texas. Based on the research, this definition was developed about this operational definition of an organization, of a CHW organizational performance, was developed. And so a high-performing CHW organization focuses on providing organizational support, fulfilling the professional needs, and gaining the trust of its members in order to improve members' social identity and perception of organizational performance, which increases member satisfaction. So that's all of that framework summed into one sentence. And I also wanted to share these words of gratitude from one of the CHWs that I interviewed. She really expressed and thanked me for asking her how she felt with the organization, if she was satisfied, what did she need, what else did she need to do her work as a CHW. You know, she said a lot of times we're given resources to take back to our community, but this, you know, when I got this email, it really stood out to me because it's asking me about me. What do I need? And so she just wanted to express her gratitude, and so that I really appreciate that, and I'm taking that and using it to motivate me to continue doing this work. And so again, this contact information is wise. Julie was on my dissertation committee, and so she is also familiar with the research, and so thank you all for your attention and your time.
Thank you so much, Julie and Denise, for your presentation. You ended right on time. And we hope we'll be able to partner with you both again to get this research out there. For our next half an hour, we will be spending talking about building a CHW program, the AUCH experience. This presentation will be given by Cynthia O'Connor and her team. Cynthia O'Connor is the Community Health Services Division Manager and AmeriCorps Program Director at the Association for Utah Community Health, or AUCH. She oversees AUCH's direct service projects through Utah. Cindy was born and raised in New Jersey, but relocated to Utah from the Washington, D.C. area and joined the program in December 2017. Cindy has several years of experience in federal and state program and project management and has overseen and implemented local and international projects for several federal and local government agencies. Cindy is passionate about community-based and culturally sensitive approaches to health education and promotion, and enjoys working with community stakeholders to serve Utah's diverse population. And I'll hand it over to you, Cynthia. Thank you.
Thank you so much. Hello, everybody. Welcome to this session, Building a CHW Experience, or the CHW program, the AUCH Experience. Again, my name is Cynthia O'Connor. You can call me Cindy. I also have Amelia Brown and Michelle Rangel with me, and I'll give them a chance to introduce themselves a bit later on. Next slide, please. So first, I'd just like to start talking about what is AUCH, just to give you some background and context on what we do as an organization. So AUCH, the Association for Utah Community Health, is a primary care association. We're the PCA in the state of Utah. And so we are tasked with supporting Utah's health centers, federally funded health centers throughout Utah, as well as all of their umbrella clinics across the state. So as many of you know, health centers provide access to high quality primary and preventative health care services to individuals and families, regardless of their ability to pay. And so AUCH, as their PCA, provides training and technical assistance to provide support with grant compliance, quality improvement, legislative assistance, so on and so forth. And so really, at the end of the day, AUCH and the health centers, we exist to serve the underserved. Next slide, please. So here is just a brief timeline of our CHW experience to date. So our CHW program is really rooted in national service. So as of 1995, we've had an AmeriCorps program, and for those of you who aren't aware, AmeriCorps is a national service program. There are AmeriCorps programs all across the nation that focus on different areas of need, from healthcare to conservation to education. We have had one since 1995 called the Utah Healthcare Corps that focuses on providing access to healthcare and social resources for underserved populations across the state of Utah. So fast forward quite a few years later, we were awarded funding to implement a CHW pilot project with the Utah Department of Health and Intermountain Healthcare. This was a pivotal point for AUCH and also for CHW work in the state as well, because this was also an opportunity to build our CHW section and coalition, and to also start formally the state curriculum for CHWs. And then in 2018, AUCH became involved as a partner in the Alliance for the Determinants of Health, which is a statewide project, pilot project that's focused on addressing social determinants of health, specifically for pilot populations in Washington and Weber County who are recipients of Select Health Medicaid. And then in 2020, and fast forward, which I'm sure a lot of you have shared this experience as well, we've seen a lot of continuous growth, a lot of attention around the CHW role in services, and have been asked to partake in COVID-19 emergency response. Next slide, please. So just to give you an idea of what the structure of our division looks like, so the Community Health Services Division is really the home for our CHW programs and services. We have reached a point where we have grown so much that we quickly realized we needed to establish a formal structure to support our CHW teams and to also meet our project requirements. So CHS, Community Health Services, came out of that. We implement all of AUCH's direct service projects, and I just want to be clear that not all PCAs really involve themselves in direct service projects. This is a kind of a unique aspect of AUCH and definitely a unique division here at AUCH. But needless to say, all of these direct service projects and programs that we're involved in are built upon AUCH's CHW program. And our mission as a division is to provide access to healthcare and social resources to underserved populations across the state of Utah. We have quite a large team spanning from all the way, in southern Utah down by Zion, all the way up to Weber. And so we've grown significantly over a short amount of time, and we've been lucky to be able to have the opportunity to establish the infrastructure to be able to support that growth. Next slide, please. So this is an overview of staffing to give you an idea of how we staff the division to ensure that we have proper support for our CHW teams, and then of course also the projects that we're supporting to make sure that we can meet expectations. So we've got roles listed here by function. So the way I like to break this out is first and foremost by operations and administration. So think more of those on the back end. That is primarily two positions, the division manager, which is me, and then our program coordinator, Heather Holliday. So we take care of things like logistics and contracting and new business, staff hiring, so on and so forth, all that work that needs to go on behind the scenes to provide that support for the CHWs to actually be able to go out and provide that direct service. Then we have our CHW technical expertise and our CHW team management. We have three positions there. One is our program manager, who's on the line, Michelle Rangel, and then we have two project managers, Sarai and Laura. And all of these positions kind of maintain their own portfolio and oversee their own CHW teams that are tied to particular contracts and stakeholders. Then we have data collection and analysis. We have one data resources coordinator, Kim, who manages our case management system and the data extraction and analysis of what we're putting into that system. And then of course, we have our CHWs who provide our direct service, our CHW services on the ground. Currently, we have over 20 CHWs. We are hiring for more for some additional projects. And at the moment, we have about 9 projects, ongoing projects throughout the state. Next slide, please. What is a CHW? So I think it's important here just to clarify what definition AUCH uses for a CHW. There are so many out there, and we think that this one organizationally really captures the work and just the personality of our CHWs and what we look for. And that is a community health worker is a frontline public health worker who's a trusted member of and or has an unusually close understanding of the community served. This trusting relationship enables the worker to serve as a liaison, link, intermediary between health and social services and the community to facilitate access to services and improve the quality and cultural competence of service delivery. Next slide, please. Now we're going to get a little bit deeper into who is an AUCH CHW. And I think it's important here to highlight that we truly do have CHWs from all walks of life. We have organic CHWs who have been doing this for their entire lives, informally and now formally. We also have some public health students who are, really interested in trying to understand the communities that they're serving and really trying to see what barriers communities are facing on the ground firsthand. And we really have found this blend of CHW experience to enrich our program overall. We find that it expands the capacity of our program and our CHWs as professionals and just individuals. And it also helps introduce new perspectives and skills. So we've found this to be quite an enriching approach for us. We do leverage our AmeriCorps program to expand our capacity. So we do have a few AmeriCorps members that AUCH oversees that are assigned to a couple of our CHW projects. They carry a bit smaller of a caseload. We like to think of them as more entry level. And they're really meant to expand the services that our full-time community health workers provide on the ground. What do we look for when we are hiring? So I get this question a lot, especially from stakeholders that we partner with. And I always say it's really about personality. It's really about the individual. We want to make sure that they're compassionate, that they're personable, that they have some experience with advocacy, personal or professional, both are extremely valuable, that they're from the community or that they're sensitive to the target community, that they have a desire to learn, they're a critical thinker, and of course they're bilingual or multilingual, depending on the community that they're serving. And so really at the end of the day, we want to make sure, are you someone who is going to be able to make a connection with your client, maintain that connection, and be able to walk them through these sometimes very difficult scenarios throughout the client's life. A little bit about AUCH-CHW training and what we do to set our CHWs up for success before they go out into the field to work with their clients. So we do have kind of a training and onboarding cycle. Generally, we try to keep new hires to about 3 times a year. We do that in January, May, and September. We as an organization are a Utah Department of Health CHW curriculum host site, and so this means that we will host at least one curriculum specific training per year. We did our first one back in May virtually, of course. We intend to hold at least one more this year, likely in September, but definitely next year. And then we have quite a robust orientation. It's several days. Generally, we'll span it over 2 weeks. And we break it down into CHW core skills. So essentially, what are the fundamentals that we feel you need to know to be successful in this role? And of course, it's not meant to be a catch-all. You're not going to learn how to be a CHW just from a training, but we've kind of cherry-picked some of the key things that we think are fundamental, like motivational interviewing, like trauma-informed care, so on and so forth. We also provide AUCH-specific training, so this would be things that are unique to our organization. So what are our HR policies? What is the case management system that we use? How do you use it? So on and so forth. We also include time to shadow experienced CHWs. So we'll pair up our new CHWs with those who have been doing this work for a while, and they'll shadow them. They shadow our different teams just to see how the different teams operate, because they don't all function in the same way. So we like to expose them to all of our projects. We provide individual team training. So this would be training with the team's direct supervisor and their peers specific to the project that they are assigned to, and the nuances and expectations that come with that. And then we provide individual support as needed. So for example, we've had CHWs who aren't super familiar with how to use a computer, how to use Microsoft Suite or technology in general, or reporting, things like that. So we'll take a look at what the individual needs are, and then we'll make sure that we provide the time necessary to introduce and refine those skills. Aside from that initial orientation, we provide ongoing continuing education. So we have a monthly continuing ed program. It takes place the 3rd Thursday of every month. And generally, we like to bring in an outside expert to speak about local resources or to introduce different populations. And that's been really helpful over time, especially to learn from our CHWs what they're needing. We always let our CHWs know, like, hey, come to us and let us know what you need. What do you feel like you need more training on? Is there a particular population that you're now starting to encounter more than you were, that you would like to learn more about, or what resources exist for them, so on and so forth. So that's a really dynamic program that we try to get input from our CHWs for. Next slide, please. Our program goals, this is just a quick summary of what our program goals are. We have so many, but we tried to cleanly and just neatly put them into 5 main points. First is to identify social determinant of health needs and what resources exist to address those. 2 would be to provide appropriate referrals to community agencies and resources for our clients based on that. 3 is help clients address their complex health needs by working in collaboration with the client's clinical team or their care team. 4 is to help clients navigate the social and healthcare systems. And 5 is to improve client engagement and empowerment and overall community capacity. We have a couple of service delivery models. And so the first one here is really managed care. We have a couple of contracts with managed care organizations, and The workflow for that is fairly straightforward. Our CHWs will receive a referral directly from a care manager, and then they'll work with that care manager and the client to help address that client's needs and then report back to the care manager. So they very much work as a team. And then, of course, we have a more community-based model where our CHWs receive referrals directly from community-based organizations as well as clinical teams to follow that same CHW process. Next slide, please. Our referring criteria and workflow. So over time, since the start of our program, what we have found is there are so many individuals that could benefit from CHW services. We had to find a way to whittle that down a bit so as not to overload our CHWs, and then to also to be able to deliver on our projects and on our services. So we've found that individuals who meet the following criteria are typically the best fit for our CHW services. They have one or more chronic condition and one or more of the following. A condition that's uncontrolled, 2 or more social determinant of health needs, no primary care provider, uninsured, or a recent visit to the ED, we usually say within the last 3 to 6 months, depending. Now, in general, as I mentioned, a lot of our CHW teams, or most of our CHW teams, operate a little bit differently, but in general, the workflow across teams looks something like this. Our CHW team lead would receive the referral. That lead would assess the team caseload, just overall skill sets and experience, and then assign that referral to a CHW. The CHW would conduct their initial intake, which would include a prepare and PAM assessment, which I'll talk a little bit more about. The CHW develops their care plan, which includes setting goals with the client. And then once the CHW care plan goals are met, the CHW would close the case. And what's important to mention here is that throughout this entire process, the CHW is reporting back and working closely with the referring partner. And to be clear, that doesn't mean that it's a transfer of care for us. So by no means, when we receive a referral from a care manager, does that mean that we are now the sole provider for that client. We're really meant to complement the work of the clinical team or that other referring entity if they're not clinical. And generally speaking, our CHWs work with clients for up to 6 months at a time. Beyond that, we would take a look at the case and see what the needs were. Generally, at that point, we would say, okay, longer than 6 months, we might need to pass this case on to someone like a social worker or someone with some kind of license, depending on what the needs are and how chronic they are. Next slide, please. Diving a bit deeper into the assessment tools that our CHWs use. So the first is PREPARE, the protocol for responding to and assessing patients' assets, risks, and experiences. So this tool, which was developed by NACHW and AUCH and the OPCA and IAF, our CHWs give this at intake. And it's important to mention here that PREPARE, especially for us, is meant to be a conversation and meant to be a relationship building tool. So rather than our CHW entering into, a meeting with a client with, a checklist and kind of just walking through questions and then checking off boxes, we really have trained them to make this a conversation, to build the client's trust, and to just in general establish that relationship to kick things off and make it a more personal experience for them, perhaps something a bit deeper than they would get in a clinical setting. The second tool that they use is the Patient Activation Measure, or PAM. This is a quantifiable tool by Insignia Health that determines patient engagement. Generally, our CHWs will provide this at intake, 1 month, 3 months, and once the case is closed. With PAM, we're able to generate an engagement score, and from there we can assess behavioral change or intent to change behavior based on that score. One of the challenges that we've had as a program is we're not embedded into clinics. We don't have access to electronic medical records and things like that, so it can be difficult to quantify any changes to health outcomes. So PAM is really one of the only things that we do consistently have as a program to measure any kind of change. So we're sure to use that with all of our clients. So we use these tools, both of them, to establish a care plan. And of course, the CHW's care plan has to reconcile referring partner and client priorities. So I'm going to hand it over now to Amelia Brown to talk about our referral and case management process. Go ahead, Amelia, if you'd like to introduce yourself.
Thank you so much, Cindy. My name is Emilia Brown, and I've been working with AUCH as a community health worker since 2019. And I have the great opportunity to be part of AmeriCorps in 2017. I was visiting one of the community-based organizations, and I offered myself as a volunteer, and I noticed the need for the help for a lot of people in my community, especially for the ones who, exactly like me, they're immigrants. And for example, when I arrived to the United States, I didn't know the language, and I was pregnant, and then to try to jump on those barriers, those are the motor for me to help some other people. I was invited to talk more for my personal experience as a community health worker, what I'm doing during the normal day as a community health worker. I will remove my camera and you can see the whole page on this one. And the community health worker referral and case management process. We can divide this in 3 single steps. The first one we call awareness, because when a patient goes to the community-based organization, or they go to the emergency department or mental local health organizations or some other points of care, thanks to them, they identified who are going to be our clients, because they use the tool Cindy was mentioning, the screening process. And after that is when we start the collaboration with those referring partners. First, for example, in my day, I receive a referral, and after that, I call back to the clinic, for example, and I try to obtain the necessary information. What is happening with this patient of yours? What are the immediate assistance they need? And I feel so proud because in our team, we receive the referrals and we try to call them immediately. It's not like a medical referral and I need to wait several weeks. We try to work on the same day. We call the second step the assistance. Community health worker, after we know some information, we contact our clients and we do an assessment also with them. But especially we need to try to identify if they already have some inventory in their hands, because usually when someone has a need, they already call their friends, if they have a support system, of course, but some other ones, they try to investigate. We ask what they're doing for themselves, and is when we enter and we try to be the connectors and we start developing a care plan. This care plan includes goals, but this needs to set by the client. Community health workers, we're going to be use a team. For example, if that referral was for food insecurity, immediately, if it's for that day, of course, we can go to the food banks and try to pick up a food box, and we can deliver that to those patients. But also, what happens if that family needs assistance with something else? And for example, education, or they're ready to lose their home, or they lose their home, of course, we're going to try to find immediately those shelters, or put the family members on the listings, waiting list for housing, etc. The third step we call the alignment. This coordination is with the referring partners. For example, today we have our weekly meeting, and every time the care managers or care members teams, or even the RNs, they start talking about their patients, and they communicate with us saying, okay, this is happening, and the next appointment for the neurology is going to be in X numbers of days. And we gave also the information to them for what we're doing. Our client, he already applied for housing. He already filled all the information about food stamps, etc. And after that, they already know what is going on with that patient. And for us, we're building that information, creating those goals, and helping them to be self-sufficient. Next slide, please. Thank you. At this moment, for me as a community health worker, I'm receiving the COVID-19 patients, and those are for the testing sites. And the first step for me is to contact them and try to identify the social determinants of health or their needs, or what kind of barriers they have in order for them to be on isolation or the family to be in quarantine. The common referrals we're sending a lot is, for example, I called the dad, he's sick, the mom is sick, they cannot be working because they need to be at home, and they have some other 2 or 3 kids that are sick. And we try to identify those immediate needs. If they need food immediately, of course, we can go to the food bank and we deliver those. We deliver the face masks, thermometers, etc. But we try to be with them over the phone, of course, and to pass that education and invite them for the vaccines. And also, if they don't have insurance, try to invite them to have the insurance. If they can qualify for Medicaid, immediately the telephone numbers for workforce services, but especially to pass that information, because many of them, they don't have primary care providers. We invite them to have a primary care provider, and also identify if they need to use the hospital. Try to avoid the overuse the emergency department. But if they need that, of course, we're going to invite them to go. But if no, we try to educate those families. These cases are different. Like Cindy was mentioning, sometimes we work with our clients for over 6 months, 1, 2, 3 of 6 months. But this one, we need to close those cases in 3 weeks. Next slide, please. One of the barriers we encounter a lot is many people, they don't know exactly, especially on the clinics, what exactly is a community health worker. And I encountered that a lot because they think we're the social workers, we're the one who can do miracles outside, but no, we're community health workers, and we are the supporting clinicians, and the collaboration, especially the collaboration, and the role delineation is a big key for this huge door. Because the care manager, they will do something, and the community health worker, we're going to do something else. For example, with them, they will do the clinical assessments. For us, we can do the social needs assessments. For them at the clinic, they can do the clinical referrals to go to the pass to the neurology, allergology, allergy doctor, cardiology, etc. But for us, we're going to pass the referrals for housing, food, workforce services, and some other social needs outside. For them at the clinic, the care managers or care coordinators, they do the health education. And for us, we also do with them health education. For them, the care managers, they do medication management. But for us, as a community health workers, we help the individuals to adhere and to follow the instructions how to take their medications. Then the things outside. One of the things I really love about this is try to invest my time and to let them know, okay, we're the ones who can help over there on the community. We're the ones who are on the street. And the coordination between providers, that is very important because we help them also. Sometimes we go to the huddles and they invite us, and we can let the providers know what is happening with their patients, and they can open their eyes. The high blood pressure is not just to take the medication, it's because the families lost a member of the family, they lose their job, and they have under a lot of stress, to understand a little bit more what is happening outside. And I have the honor to introduce also my my manager, Children Health. She has a lot of experience, and I learn a lot from her in this field.
Thank you, Emilia. Hi, everybody. I'm Children Health and Community Health Service Program Manager. I think some of these things already Emilia covered in the first part of her presentation, but I think it's important that we highlight some of the focus that on how we understand CHW leadership in our program. And it's very important for us to recognize and highlight the leadership role that the community health workers have in the community. They are trusted members of the community, and they are in a special position where they can create systematic change. So some of the things that we really like to support or highlight is avoiding CHW medicalization. So although we really, we are always promoting a collaboration between clinical teams and CHWs, we trying to be respectful, and we are advocating always to be respectful of CHW's scope of practice and make the differentiation between the two of them. Also advocating for accessibility of services. We know that as a trusted member of the community, the CHWs are in a special position to bridge the gap, to advocate, to bring a voice for those communities who don't have the space. And we encourage our CHWs to use those relationships they have on the front line with organizations, with CBOs, with agencies, with clinical teams to bring those concerns, to educate providers about barriers, and try to create a systematic change that is in benefit of the community at the end. Promoting CHW work, we are a strong advocates of CHW work, so we are always talking about it in those spaces, and we understand that many people have been working in this field and not knowing that they are community health workers. So whenever we have the opportunity to interact with CBOs, with agencies, with any groups, or even with community leaders, we talk about community health work, and we help and recognize some of those skills that community health workers have in some of the work and the advocacy work they have been doing for years, so they can make the connection between community health work and people they see working every day with those communities. We think it's very important that they get recognition, and so that the profession gets recognized in general. Highlighting the benefits of CHW collaboration with the clinical team. As you probably noticed, we really like to foster collaboration between the clinical team and CHWs. We think that the CHW role is so special and unique that it has a special place everywhere, obviously the social system, but also in the clinical teams. And we try to, every opportunity we have, to educate clinical providers about the benefits, how CHW support helps the clients to be empowered about their healthcare, and also how empower the client to overcome social barriers and financial barriers. And I think this program provides an opportunity for us as CHWs to create a change with the medical field, with the clinical teams, without being part of the clinical teams per se. And also, lastly but not, the last point is very important: fostering community capacity and building efforts. One thing that we really like is to encourage our CHWs to participate in any space where they can be representing and providing that representation and advocacy. And our CHWs participate in committees and groups, they volunteer. So it's very important for us to foster and encourage that participation for our members of our team. And I think we go to questions. I don't know if we have any time for questions.
Unfortunately, we're going to have to wrap it up now. Thank you so much for all of our presenters for your great insight. And everyone who joined, thank you so much. We will now have about a 10-minute break, a little more like an 8-minute break now, and then folks can move on to the roundtables. Thank you so much, and I hope everyone enjoys the rest of the Unity Conference. Bye.
Bye.